Is Damiano Gentile from Human Intensive Research Hospital, coming out to us virtually. He will discuss preservation of axillary lymph nodes compared to complete dissection in T1-T2 breast cancer patients presenting with 1 to 2 metastatic sentinel lymph nodes, a multicenter randomized clinical trial, Sinodar One. Dr. Gentile.
Good morning, everyone. This is Damiano Gentile from the breast unit of Humanitas Clinical and Research Center in Milan, Italy. First of all, let me thank you, the San Antonio Breast Cancer Symposium Committee, for giving me the possibility to present the results of our study, which is a multicenter randomized clinical trial, the Sinodar One trial. So, axillary lymph node dissection has always been part of breast cancer treatment since it was firstly described by Halsted. However, during the past 25 years, surgical management of the axilla has shifted towards a more conservative approach. It is certainly true that axillary lymph node dissection is an effective procedure for an accurate axillary staging while ensuring a satisfactory locoregional control. However, it is associated with a significant risk of complications such as pain, lymphedema, numbness, and restricted shoulder movement. The minimally invasive and less morbid procedure of sentinel lymph node biopsy has replaced axillary lymph node dissection in clinically node-negative breast cancer axillary staging, demonstrating optimal disease control and not compromising long-term survival. Until now, axillary lymph node dissection has remained the standard surgical technique. Sentinel lymph node is macrometastatic. However, complete axillary dissection may now be considered an over-treatment for early-stage breast cancer, and this recommendation starts being challenged based on the following consideration. Diagnosis tends to be earlier by screening mammography, so patients present with smaller tumors and lower axillary burden. Less than half of the patients with sentinel lymph node metastasis presents additional metastasis in other lymph nodes. The majority of sentinel lymph node positive patients not undergoing axillary lymph node dissection will receive chemotherapy and/or endocrine treatment, maintaining low locoregional failure rates. The American College of Surgeons Oncology Group Z11 randomized clinical trial has questioned the therapeutic benefit of axillary lymph node dissection in patients with metastatic sentinel lymph node, setting the ground for introduction of axillary dissection omission in the surgical management of node-positive patients. Patients undergoing breast-conserving surgery and whole breast radiotherapy with 1 or 2 metastatic sentinel lymph nodes were randomized to axillary lymph node dissection or no further axillary treatment. The trial concluded that axillary dissection did not provide outcome advantages and no significant difference between axillary lymph node dissection or sentinel lymph node biopsy only groups was reported with respect to axillary recurrence, recurrence-free survival, and overall survival at 9.3 years. However, these results are controversial due to various study limitations. The trial was underpowered because premature enrollment conclusions. Too many patients were lost to follow-up, and about half of the patients presented macrometastasis. Moreover, there was a lack of radiotherapy quality assurance, with missing data for more than 2/3 of randomized patients, with a significant number of protocol deviations and the use of high tangent fields. These limitations make it difficult to generalize the findings of the trial and imply the need for stronger evidence to support the recommendation of axillary lymph node dissection omission in sentinel lymph node positive breast cancer patients. Based on this consideration, the breast unit of Humanitas Clinical and Research Center in Milan promoted the Italian multicenter randomized clinical trial Sinodar One. The Sinodar One trial is a prospective non-inferiority multicenter randomized study aimed at assessing the therapeutic role of axillary lymph node dissection in patients undergoing either breast-conserving surgery or mastectomy for T1 or T2 breast cancer presenting one or two macrometastatic sentinel lymph nodes. The enrollment of the study ended in April 2020 and follow-up is still ongoing. 52 different Italian centers participated to this study. The study was designed as follows. All patients with T1 or T2 breast cancer with one or two macrometastatic sentinel lymph nodes undergoing any kind of surgery, either breast-conserving surgery or mastectomy, were randomized into two different treatment arms. The first treatment group was composed of patients undergoing standard treatment, meaning complete axillary lymph node dissection. The second treatment group was composed of patients undergoing only sentinel lymph node biopsy. After surgery, all patients were candidate to adjuvant treatment according to the breast unit multidisciplinary meeting. All candidates were aged between 40 years and 75 years. They all had a histopathological diagnosis of invasive breast carcinoma, which was unilateral or unifocal. The dimension of the tumor was less than 5 centimeters, and all patients had no metastases and they did not undergo any kind of neoadjuvant therapy, meaning no neoadjuvant chemotherapy or endocrine treatment. So the randomization of the patient ended in April 2020 with 889 patients randomized. The two different treatment arms were homogeneous in terms of number, and only few patients were excluded for missing data or errors in randomization. As regards axillary treatment results, we can see that there was a median of 2 sentinel lymph nodes in both treatment arms, and as we analyze the type of metastasis of the sentinel lymph nodes, overall we can see that there were only 5 cases of micrometastasis, with 2 cases of micrometastasis in the standard arm and only 3 cases of micrometastasis in the experimental arm. And as we analyze non-sentinel lymph nodes, meaning when we analyze additional lymph node of the axilla in the standard arm, we can see that there were additional 193 additional patients with more positive non-sentinel lymph nodes, meaning that 44% of patients in the standard arm had additional lymph nodes macrometastatic in the axilla, meaning that there was a mean positive non-sentinel lymph nodes of 1.4 and a median positive non-sentinel lymph nodes of 0. As regards surgery of the breast, we can see that there are homogeneous results between the two different groups of treatment, but these homogeneous results within the same group. As we can see, almost 80% of patients in each group underwent breast-conserving surgery, and only 20% of patients in both groups underwent mastectomy, either total mastectomy or nipple-sparing mastectomy. And now let's analyze the follow-up data. Let's see the events and survival. There were only 16 events in the standard arm of treatment and 20 events in the experimental arm. There were 4 cases of mortality in each group and only 1 case of axillary recurrence in each group. 3 cases of ipsilateral breast cancer recurrence in the experimental arm, 7 cases of distant recurrence and 8 cases of distant recurrences in the standard arm and experimental arm respectively. So as we can see, there were no statistically significant difference in terms of both survival and recurrence in the 2 different groups of treatment. And follow-up was similar between the 2 different treatment groups with a median of 34 months overall. So when we analyze the long-term oncological outcomes of both groups in terms of recurrence and overall survival, we can see that both in the intention to treat population and in the per protocol population, there were no statistically significant difference between recurrence and survival. Additionally, when we analyze the long-term oncological outcomes in terms of recurrence and survival of the intention to treat population, we can see that there are no statistically significant difference between recurrence and survival, also in the projection of the 5-year follow-up. So next question is, what is the median time of axillary recurrence? Greco evaluated the impact of breast carcinoma surgery without axillary dissection on axillary and distant relapses in 400 patients, showing that the median axillary free relapse time was 30 months. Fisher showed that the median axillary free relapse time was almost 15 months. Wong reviewed patients with invasive breast cancer who underwent sentinel lymph node biopsy with a positive sentinel lymph node without axillary lymph node dissection, showing a median axillary free relapse time of 32 months, and Cecchini reviewed 1,056 women who underwent sentinel lymph node biopsy without dissection, showing a median axillary free relapse time of 23 months. The median follow-up of Sinodar One trial is 34 months. Let's now analyze the difference between the Z11 trial and the Sinodar One trial. The Z11 trial concluded with a median follow-up of 9.3 years. Instead, the Sinodar One trial, the enrollment ended in April 2020 with a follow-up which is still ongoing, with a median follow-up time of 34 months. When we analyze the micrometastasis data of the Z11 trial, we can see that almost 40% of patients had micrometastasis in the sentinel lymph nodes. Instead, only 5 patients overall had micrometastasis in the sentinel lymph node in the Sinodar One trial. Moreover, there were almost 30% of detailed radiotherapy data in the Z11 trial versus almost 80% of detailed data in the radiotherapy characteristics of the Sinodar One trial, and there were 0 mastectomies performed in the Z11 trial. Instead, almost 20% of patients underwent mastectomy in the Sinodar One trial. So the overlap between the results of the Sinodar One trial and those of the Z11 trial is very convincing. So is it still correct to continue to propose complete axillary dissection to patients who meet the study selection criteria? So the breast unit of the Humanitas Clinical and Research Center, which is the study coordinator of the trial, believes that the conditions of uncertainty that justified the randomization between complete axillary dissection and the omission no longer exist. Therefore, the core team of the breast unit expressed a favorable opinion on the proposal to include in the internal guidelines the omission of complete axillary dissection. Thank you for your attention.
Just a couple questions. We're
Thank you.
6 minutes behind.
Yeah, thank you, Dr. Gentile. A couple of quick questions online, and I think the first one is Z11 was for clinically non-negative patients, but the question says that in your schema, actually, you showed there was clinical N1, but I think this was a study for clinical N0 patients, if I'm not mistaken. Is that correct? Can you hear me? I'm not sure if Dr. Gentile can hear us. Can you hear us, Dr. Gentile?
Okay, this might be a great example to move on.
Yeah, I think so. But I think, again, I will try to answer it myself. I think this, and he corrected it later on, is for clinical N0 patient. I think since we cannot hear, Dr. Gentile, you cannot hear us.
Yes, now I can hear
Can
you.
you hear
Yes.
me? Okay. Just to clarify, this was a study for clinical N0 patients with 1 to 2 positive sentinel nodes, correct?
Clinically and radiologically N0 patients.
Right.
They were checked with ultrasound, axillary ultrasound.
Great. And also another question was ERT to the axilla, I guess radiation to the axilla avoided in the breast conserving surgery group with 1 to 2 sentinel nodes?
Exactly. They avoided the axillary zone, so the radiotherapy was directed into the quadrantectomy, and some patients also received a boost, a radiotherapy boost. But other than that, the axillary region was avoided.
Did the patients undergoing mastectomy receive radiation?
No, they didn't.
They did not. Very good. Okay. I think we're a little bit behind, so I think we'll move on. Thank you very much for your presentation and answering.
You're welcome. Thank you.
Thank you.
You're welcome.